Good afternoon, everyone. Welcome to the Global Interdependence Center's executive briefing. I'm Bill Kennedy, your host. This is our 6th edition of our Analyzing Pandemic series, and today's presentation is titled The Pandemic Challenge, Preparing, Responding, and Preparing Again. We think this is a most appropriate title given that this is National Nurses Week. It runs from yesterday, May 6th, which was actually National Nurses Day, to May the 12th, which is the birth date of Florence Nightingale, who was born in 1820. Every nurse is a leader who motivates people to act towards a common goal. And this year, the extraordinary leadership exhibited by nurses gives National Nurses Week even greater meaning. Our nurses have sacrificed everything towards a common goal of saving lives and responding to the COVID-19 pandemic. For these reasons, the GIC is proud to dedicate today's event to all of our nurses, and we say to all of our healthcare workers, thank you. So before we introduce our guests, let's take our quick audience survey. So Colleen, if we could start the survey, we have 5 questions. The first is, the world is globally interdependent. In 2 years' time, will we be more or less interdependent? And you just can move your cursor over the answer and select. And next. When do you expect an end to social distancing and business closures? May to June, July to August, 4th quarter of this year, or 1st quarter of next year? Okay, next question. When do you think people will be comfortable getting back on an airplane? Same time frames, May to June, July to August, 4th quarter, or 1st quarter of next year? Next question. Are you personally willing to use a mobile app that would assess the threat of COVID-19 exposure by tracking your location and your personal contact data? Yes or no? And our final question. If you're considering an elective surgical event, is your expectation to have that elective surgery this year, next year, or would you cancel it altogether? That's great. Thank you very much. So today, I'm very pleased to introduce Dr. Judith Monroe, who is the president and CEO of the CDC Foundation based in Atlanta, Georgia, where she has served since 2016. As our mutual friend David Kotok of Cumberland Advisors says, the CDC Foundation is a little special gem in the United States. The foundation's goal is to keep people healthy and safe by mobilizing philanthropic and private sector resources to support the CDC's critical work. Dr. Monroe has dedicated her entire career to protecting people and saving lives. She joined the CDC Foundation following her role as a deputy director at the CDC and as a director of the CDC's Office of State, Tribal, Local, and Territorial Support. She has served as a state health commissioner for the state of Indiana, where she was the president of the Association of State and Territorial Health Officials through the H1N1 pandemic in 2009. Dr. Monroe currently serves on the boards of the Center of Global Health Innovation and for the Georgia Global Health Alliance. She's a member of the Milken Institute Public Health Advisory Board and serves as a member of the World Health Organization Foundation's Advisory Group. Dr. Judy Monroe, welcome.
Thank you. Great to be with you.
So before we get into your prepared remarks, I'd like to ask a question, given that background. What's the greatest challenge of this pandemic, of the COVID-19 pandemic, compared to other health threats that you have seen and experienced in your career?
Yeah, no, that's a terrific question, and I've seen several health threats throughout my career, as you just indicated. This one is the biggest one I've seen, and all my colleagues are saying the same thing. And the threat here, I think the greatest thing is because of the scale and severity. It's that mix between the two. H1N1 was a pandemic, but it wasn't. We didn't have the same severity, and quite frankly, this economic, the devastation to the economy that this one has brought brings with it additional health consequences in addition to the threat of the COVID virus itself. So it's a bit of a perfect storm, and everyone I know in public health is saying, this is the biggest thing they've seen in their careers.
Very interesting. Well, I know you have prepared remarks, so we're going to put your slides up now, and we'll turn it over to you.
Great. So, well, thanks so much. It's great to have the opportunity to join you this afternoon. And I will tell you, it almost seems like an understatement anymore to call this pandemic a challenge or to say it's unprecedented. We've heard that word many times. We almost need new language. This is going on so long. It's a little hard to believe, however, that it was, if we go back 6 months ago, that none of us had even heard of SARS-CoV-2 or a name such as COVID-19. It's really difficult to understand how time has expanded. Folks are calling COVID days like COVID weeks and weeks like years. So we'll go to the next slide. Just a little bit about the CDC Foundation. We are 25 years this year, celebrating our anniversary, and in many circles we've been a bit of a well-kept secret, but that has changed in a very brief span of time for us, given the pandemic. We'll go to the next slide. So the foundation, what we like to think about as our work is that we unleash the power of collaboration between the Centers for Disease Control and Prevention and philanthropies, organizations, corporations and governments, as well as individuals. And that has had no greater impact than right now during this pandemic. We do believe that by aligning diverse interests and leveraging each party's unique strengths, that coming together through those types of collaborations, our impact really is greater than we can do alone. And the foundation, we've got a lot of programmatic work that we do. We're in 130 countries with projects, and we have regular programmatic work. But we also have responded to other challenges, such as the Ebola epidemic, Zika, and Hurricane Maria are some of the recent emergencies. Next slide. So our mission, and what's interesting about the foundation, we're a little bit different than your typical foundations that you might hear about. We're an operating foundation, so we actually do a lot, as well as helping to raise resources to help CDC. We're an independent nonprofit, but we were actually created by Congress to be able to support the Centers for Disease Control. So the picture here is actually headquarters of CDC here in Atlanta. And the agency itself, of course, you hear about all the time, and especially now. And I will tell you, they are working 24/7 to protect America's health, safety, and security, and both threats here at home as well as around the globe. They do that, of course, by fighting outbreaks such as the pandemic. But as we're having this pandemic, we're having other smaller outbreaks that you may not hear about with other infectious diseases. They also work hard to reduce healthcare spending through some of their prevention programs, healthcare-acquired infections, as an example, trying to keep healthcare safer, and then providing essential guidelines and health data. And this, I'll get a little more into that, but that's a big part of what the CDC does, taking science and turning it into guidelines. Next slide. So COVID-19. Moving into that, this is the novel coronavirus that shut down the world. And some examples of shutting down the world, if I look just right here in Atlanta, the Hartsfield-Jackson International Airport, Georgia's largest employer, has seen a huge loss of revenue and passengers. Passengers are down 85%. 70% of hotel employees nationwide have been laid off or furloughed. And we now have more than 30 million initial claims for unemployment that have been filed over the course of the past 6 weeks, which of course is a historic reflection of the economic impact of the COVID-19 pandemic. And then just to put it in a little different perspective, things that you might not think about, adoption experts are telling us that all the emotions that we might be feeling, anxiety, fear, are all amplified in these children that are waiting for adoption, and the pandemic has paused adoptions and left some children in limbo as they are living in temporary houses, group settings, unaware of where they might go. Multiply that times folks all over the nation and around the world, the disruption it has had really for everyone. Next slide. And this slide, of course, many people have been going to the Johns Hopkins site to see the spread of COVID. And of course, it started there. That first announcement came December 31st, so New Year's Eve. And we have been really dealing with this throughout all of 2020. You can see the numbers just continue to increase. Since this slide was made a couple of days ago, we've already surpassed over 70,000 deaths in the US as an example. And we're approaching 4 million total cases worldwide. One of the things that I think is important here is the US has since become the hardest hit nation across the globe, with about a third of the world's reported cases and more than a quarter of the world's deaths. The next slide will take us to a timeline, kind of how we got here, and this just a reminder of some of the big things that happened. Of course, New Year's Eve, we did hear about this case of pneumonia being reported out of Wuhan, China. It was January 10th that China did share the genetic sequence. And then on the 21st of January, we had CDC activating their emergency operation center, and they've been going ever since. You can see the declaration then of the public health emergency of international concern came January 30th. And then the naming that took place on March 11th, that's when we first had the declaration by WHO that it was a pandemic. But you'll remember here in the United States, things had really heated up in early March. That's when we at the foundation felt almost, there was a big tipping point that took place, I think, early March, as we started to see more cases. And we knew then that there was community spread here in the US. So by March 15th, CDC had recommended that we begin to cancel events with 50 or more people. And then, of course, following that, we started having orders to stay at home, as the timeline shows. So we also now are looking at mid-April were the new guidelines for being able to reopen the US. So that's how quickly we shut it down. And now we're at this threshold of how do we safely reopen. One to the next slide. So this is a novel virus, and I wanted to say a word about this. It's important to realize that this is the first time that a coronavirus has, in fact, caused a pandemic. We've had pandemic. You hear a lot about influenza pandemics. And of course, there was the plague and different things throughout the centuries. But this is the first time a coronavirus has done this. And as a reminder, we all heard about SARS, and SARS really changed the world in many ways. SARS is a viral respiratory illness, and it's also a coronavirus, but with a lot of differences than this one. That's an illness that spread to more than 24 countries in North America, South America, Europe, and Asia back in 2003, and then it was contained. So it wasn't a pandemic, it was an epidemic, this outbreak. And since 2004, we had no further cases of SARS being reported. Another coronavirus that you all are probably quite familiar with is MERS, or the Middle East Respiratory Syndrome. And this, again, a coronavirus that caused this. We know that people that have MERS develop severe respiratory illness, symptoms like fever, cough, shortness of breath. In the case of MERS, 3 or 4 people out of every 10 are reported to have died of MERS. So it's got a much higher fatality rate. And health officials first reported that in Saudi Arabia in September of 2012. They later realized there was an earlier case in April of 2012 in Jordan. And all of those cases had been related to travel. So unlike the pandemic that we have now that we started having the community spread, these were all linked to travel and from countries that had been in or near the Arabian Peninsula. The largest known outbreak of MERS outside of the Arabian Peninsula was the Republic of Korea in 2015. And you may be reading now how South Korea really took that lesson to heart, and they have done a great job of containing, mitigating and containing the COVID-19. Much of that is because of their lessons learned. So when we look at these three coronaviruses, two of them didn't come close really to causing a pandemic, but their fatality rates were much higher. SARS was about 9.5%, MERS 34.4%, and COVID, the fatality rate is maybe 2%. We're still figuring that out, but it's obviously much lower, to 2.3%. But the rate of spread was different as well. MERS, if you had a case of MERS, you actually infected less than one other person. The R naught was less than one. With SARS, it was 1.7 to 1.9 people would be infected if they had contact with someone from SARS. And with COVID, it's 2 to 2.5, which is like a really bad flu season. It's higher than our seasonal influenza. So all of those factors go into why we now have a pandemic with COVID. The other thing that's happened with this novel virus is we continue to learn. And so CDC has now announced some new symptoms related to this. Aside from cough and shortness of breath and fever, some of the early things that we knew people would have, chills, now shaking with chills, muscle pain, headache, sore throat, and this new loss of taste or smell might occur if, as an early symptom or symptoms of COVID. One of the things that is quite concerning now and a bit of a mystery is what's happening with children. We know that we've not seen children really be very sick. They're not actually testing positive with the tests that we have, but now we're seeing more and more children coming in with discolored toes and feet. The dermatologists are reporting a lot of blue or purple toes, so there's a dermatological component. And now just in the last few days, we're hearing more reports of a perplexing inflammatory disease that they believe might be linked to COVID-19, and children are being hospitalized. So we also know that the virus can mutate and that there are different strains that we continue to learn about. We're still learning about treatments. We don't have a vaccine yet. And so there are a lot of unknown questions because of the newness. And how will this evolve? Will it become seasonal? All outstanding questions at this point. Next slide. So this is CDC's a photo there in the CDC Emergency Operations Center, and today is actually their 123rd day of the response. They have been working 24/7, and this, as the Centers for Disease Control, they really get busy. They've deployed probably over 1,000 people across the agency now at this point to help with the response. They staff the Emergency Operations Center, but they also send staff out into jurisdictions. So like especially when they're epicenters, so the Bay Area, Seattle were early recipients of CDC technical assistance and boots on the ground. They do that type of thing. They're helping now with contact tracing, which is really the big thing that we're looking toward. I'll say a little more about that in a minute. They support communities and businesses, and they issue guidance. So I just learned earlier today that CDC has over 1,000 guidance documents that they have developed just since the beginning of the year, as we've learned more about the science of COVID and what we're discovering with the reports that come into CDC. And those are available then to help a whole variety of folks, whether it's businesses or hospitals, the public at large around guidances. They continue to have a very aggressive response to the global outbreak as we see this community spread. Last week, they do a weekly surveillance summary, and so their website, I would invite you to go to the website because they have many, many things there. And one of the new things is a COVID-19 activity that's available through what's called the COVID View report. It's got a lot of graphs, a lot of visuals. The latest report is showing a decline in most of the key indicators used to track COVID-19 activity from the prior week, although it's modest, and it might be, in part a result of widespread social distancing measures. We do know those have been successful to flatten the curve, as we've all learned. It's kind of like the whole world has had a lesson in pandemics and epidemiology and new lingo. CDC is doing a lot with the investigations on the ground, and then they are developing an antibody test now too, so that's new. So if you go to their website, you'll be able to see. The other thing that CDC does, and I mentioned this earlier, as all attention is on this pandemic and on COVID-19, that doesn't mean other things don't continue. And one of the things that we see with pandemics and emergencies like this, and this one is hitting really hard, is the impact on other regular public health services, such as childhood immunizations. So I believe there's going to be a report actually tomorrow coming out from CDC, and we will see a decline in just routine immunizations, which means then we run the risk. We had a measles outbreak, back in the spring. We run the risk then of other diseases wreaking havoc because we're not able to do the usual things that we would do. Next slide. So for the foundation's response, just to give you an idea of how we work with CDC, CDC is in the middle of this crisis. As they find things that where they have gaps, where they have either funding gaps or they need us to move really quickly because we have a speed and agility. Being an independent nonprofit, we're pretty nimble. And so we've been asked to do everything from helping to fund medical supplies, personal protective equipment. We got very involved in that and have distributed a fair amount across different jurisdictions. We were asked to help early on to help increase laboratory capacity in some of the state labs to ready themselves for this. We are in the middle of doing search staff hiring at the foundation. We hire what we call CDC Foundation field staff, and every state is going to receive a team that we're hiring to help build their teams on the ground, as well as tribes and territories and some of the big cities. One of the things in particular that I always think of the local health departments as kind of the tip of the spear when it comes to this, and they've been very concerned about vulnerable communities. The homeless communities in many cities have been a major issue, but of course our elders and a whole array of particular vulnerable communities that we've helped. And communications is really important. Whenever there's a large-scale public health emergency, we can't overemphasize the need for good communication. We've been asked to assist with that. And then research. There are many gaps. So we're helping support a large clinical research trial right now, as well as we don't know anything about how this affects pregnancy and infants. And so there's a pregnancy registry and a trial underway that we're helping support as examples of what the foundation might do. And then we do a fair amount in the global response. Some of our funding has gone for international work, especially building infrastructure in countries that need the basic laboratory and emergency operations centers, workforce, and of course testing and so forth. Next, go to the next slide. So with all this, I mean, there have been things that have worked well. We've had the rapid sequencing of the virus. I think folks have celebrated the advancement of science along with this. Folks really were pretty quick to identify the at-risk populations to be able to get messages out to them. Guidance around protective measures came out pretty quickly. And then research, the whole world, there's a lot going on with vaccines and therapeutics and gene understanding, as I mentioned, the different strains. And then I'm not you all are the experts in finance, but from where I sit, I think the stimulus package is have worked and have been helpful with this particular situation. Next slide. So the next one is just to talk a minute about the gaps exposed. And much of this has been in the news about where we are. The first thing I would just call out is the production and sourcing of personal protective equipment. I mean, we really have had a bit of the Wild West as hospitals had to and states have had to compete for supplies. Having the supply chain primarily coming from China has been challenging, and I think we've learned the hard way that we do need to be able to think about our strategic national stockpile, both nationally at the state level and down even to the hospital or organizational level differently, and then as well as being able to ramp up production in a situation like this. Lots of opportunities for more coordination between nation sectors and industries. And then testing. Last week there was a mortality weekly review from CDC. They come out each week, although the special editions come out. So the MMWR on May 1st did acknowledge that the US government was slow to understand how much coronavirus was spreading from Europe, which helped drive the acceleration of outbreaks across the nation. We've had limited testing, and there were some delayed travel alerts for areas outside of China that did contribute to this jump in the US cases starting in late February. We've had nearly 2 million travelers arrive in the US from Italy and from other European countries during that time, and travel, the US government did not block travel until March 11th for that part of the world. In the article, they also noted explosive effect of some of the late February mass gatherings. You've all probably read a bit about the scientific meeting in Boston. Mardi Gras has gotten a lot of attention. And then here in Georgia, there was a funeral in Albany, Georgia, that all of a sudden Georgia was one of the states that had, in some of our rural communities, a pretty challenging time with the outbreak. And so, of course, these gatherings spawned many cases, and then that led, of course, to the decision in mid-March on the timeline that I showed you to begin to restrict crowds. The thing about testing, just another word about that to better understand that, is the initial test from CDC was rolled out to state public health laboratories in early February, and one of the components was discovered to be faulty. At the same time, the Food and Drug Administration has a protocol that's called the Emergency Use Authorization, or EUA, and through that, they clear tests for labs around the country for use in an outbreak. And so on February 4th, the FDA gave an EUA, or some Emergency Use Authorization, to CDC and some public health laboratories. But of course, then we had the faulty component in the lab, and so it wasn't until February 29th, the end of the month, that the FDA changed the EUA process so that labs then could begin doing their own testing, and that can be from universities or commercial labs, and they were able to begin to submit data for the FDA approval 2 weeks later. So so we did have delays in that, and then there have been some issues with being able to get samples of the virus to be able to produce the lab needed. But we do need, one of the things that clearly going forward, we need more testing capability. There have been continued challenges with ramping up the testing. A lot of this is specialized supplies and extensive instruments. You have to have trained lab technicians. And then the massive demand, and I said this early on with the question that Bill asked me in the beginning, one of the challenges with this is because it's happening everywhere at the same time with a pandemic, and so the demand for materials for the tests, for the supply chain, just create shortages every step of the way. So there's just been a lot of challenges there. The antibody testing is being done now, which folks are excited about the serology. However, there are questions about accuracy of testing, and it's not clear yet, if these tests are consistently correct. So that has to be worked out. And then an antigen test would be the fast, real mass. It's like when you go get a strep test and to see if you've got strep throat. The antigen test would be one that could be great, although right now the challenges are the sensitivities ranging from 34% to 80% according to the World Health Organization. So a lot of technical things that still need to be worked on, but we've got lots of folks around the world and around our country doing this. Next slide. So what lies ahead? So you're going to hear a lot about contact tracing and how do we reopen our country. And I will tell you, we're not going to have an immediate return to normal. A couple of ways I've heard this said is that, you know, we can't just, it's not a light switch. We can't just flip the switch and all of a sudden life is back to normal. Some have said it's more like a dimmer switch and we need to be really careful how we dial it up or dial it down depending on what we're finding. Earlier today, I heard another metaphor that I thought was interesting. They said we've got to be careful if you jump out of an airplane with a parachute and you're floating down and all seems well, halfway down, you can't, it's probably not a good idea to decide you don't need the parachute anymore and to take that harness off. And so we've got to be cautious along the way. And one of the things that authorities and experts are all saying now is the contact tracing. And so armies of contact tracers are going to be needed. This is bread and butter public health, boots on the ground, or in this case, a lot of telephone calls or getting data coming in through technology to be able to track folks that have become positive and find out who they've been in contact with so that they can be quarantined so that we limit the spread of this virus. And that's going to be really important to us reopening in a safe manner as this goes. In terms of treatments, you know, we've seen just recently, it does look like we've got a treatment now with the remdesivir that seems to have a positive effect, and so we'll see about that. And we hope more treatments come online, but that's hopeful. In terms of a vaccine, you know, it's still a bit too early. We do have 6 vaccines that are in human trials now, so that's unprecedented in terms of timeline. But still, we just don't know. It can take a while, usually 18 months for a vaccine in typical times. But we'll remain, we'll wish for the best on that. Next slide. So preparing for a pandemic, I just wanted to say a word about thinking about where do we go and what do we need to do. I think we can go to the next slide here on this one. So when I became state health officer in Indiana, I was coming out of medicine and coming into public health, and I walked right into pandemic influenza preparedness planning. At that time, Secretary Mike Leavitt was traveling around the country. There was a big push because of the concern about the avian influenza H5N1. And we thought this could be the big one. This could be the virus that spreads around the world and causes the next pandemic, severe pandemic, similar to the 1918 influenza that we've heard so much about through history. It turned out H5N1 did not cause a problem, but what we did as a country is we did a lot of preparing, a lot of planning. There are a lot of plans right now that every state has, as well as nationally. And we started to stockpile. I know in Indiana, we had stockpile in hospitals. We were pushing partners to do that. Some of our private sector partners had their own stockpiles, as well as, of course, the Strategic National Stockpile nationally. But we also were training and exercising and thinking about this. And then in 2008, 2009, when H1N1 came on the scene, we were pretty prepared as a country. Now, we got lucky. H1N1 didn't have quite the severity, and we did do some closures. I remember closing schools in Indiana, and of course, a lot of daily messaging. And then we got a vaccine, which was really fortunate. And then there was a lot of work to get everybody vaccinated. We did lose lives during the H1N1 pandemic, but I will tell you, as a country, we were very well prepared overall because we had done so much planning along the way. Next slide. So as we think about planning for the future and where do we go from here, these 3 points come from the source for this is the Pandemic Action Network, which was just announced about 2 or 3 weeks ago, a coalition coming together to advocate for better planning and taking care of things now. And the three main points here I would make is that we need to ensure full funding for the global and country level COVID-19 response. And then we need to look for future pandemic preparedness. We are seeing more infectious diseases than I think ever before. We need to strengthen the global health security architecture for more effective pandemic preparedness and response. There's been a global health security agenda for a number of years now. It went for 5 years and then it was reestablished. So we're probably in year 7 or 8 of that. But countries around the world, it has not been resourced the way it needs to be done, and we need to pay much more attention to that and take action. And then we need to accelerate research and development and access to innovations to combat both COVID-19 as we continue now, and then the emerging pandemic threats. So I will wrap up there. And
great, thank you very much, Dr. Monroe. So we're going to get to the Q&A portion now. Just as a reminder, if you would like to ask a question on the GoToWebinar site, there's a dashboard to the right-hand side. Find the tab that says questions. You can type in your question, that will put it into the queue, and we'll ask that of Dr. Monroe. While we're waiting for the questions to come in, let's go ahead and take a look at our survey results, and we can put those up. So looks like 61% suggesting less interdependent 2 years from now. Next question. So end of social distancing and business closure, first quarter of next year, about 42%. And I will say that that is, prior to this, in our previous calls, July, fourth quarter, and the first quarter have been just about equal. So it seems like it today, anyway, the first quarter of 2021 has been pushed out a bit. Next. So very similar for getting back on air travel, into air travel. So 67% said first quarter of next year. Question 4. So Dr. Monroe, to your comment about tracing, right? Here's a small sample size, but 75% suggesting they would participate in some sort of tracing program. And question 5. In terms of elective surgery, so 42% for this year, and 53% would push it off to next year, and 5% said they would cancel the surgery altogether. So that's great. We very much appreciate everyone's participating in the poll. We've got some great questions coming in. So no particular order. Let me put this first one to you. My primary physician offering a serological antibody testing. So the question is, what are the benefits to me and to the scientific community of performing antibody testing now, or should I wait for another milestone in the pandemic?
Yeah, no, that's a terrific question. One of the things that's happening are a lot of interest in serological studies. So one of the questions would be, is the physician involved in a study? Because that's going to be really important to look at population-wide. The serological testing is not 100% perfect right now, but if you test positive, you have antibodies. I mean, you may have some assurance that you've had the disease. The problem is you can't take that to the bank, so you still have to do your social distancing and beware. There are some folks that have antibodies, though, that we know are giving blood and plasma. So part of this would be the big value would be: is it part of a study, or is it an opportunity to maybe even give plasma to help with treatments of some of the folks in the hospitals?
Great, thank you for that. So we have a number of questions regarding other testing. So being tested for positive or negative for having the virus. One question, how much testing is necessary for achieving herd immunity?
Yeah, so to achieve the actual herd immunity, we would want, most folks say that you need about 60% of the population thereabouts to begin to get real herd immunity. Because this has been so asymptomatic, we would have to really ramp up testing quite a bit. And even to get back to work and so forth, most people are saying that we need to at least triple the testing that we're currently doing. But ideally, yeah, we'd want to know about, you can extrapolate sometimes with your testing, but you'd want to have about 60% that have had the disease.
And can you clarify how much testing per day is being done right now?
Oh, that's a great question. I don't know if I have the numbers off, but I looked at those numbers. I don't have them memorized. I'm not going to remember the actual number that's being done.
Okay,
Sorry about
that's
that.
fine.
Yeah.
Thank you. Again, related to testing, and you addressed a little bit about the problems with testing early on in the process. What would you say the biggest learning has been at the CDC or any of the other agencies with regard to testing for a go-forward basis?
Yeah, I mean, I think the big lesson for testing early on is the idea that you want to. I mentioned the FDA. I think the idea is you want to have other laboratories developing testing as soon as possible. We can't put our eggs in one basket, as we always say, right? So these things are complicated, developing these things. So to have a test that is faulty is going to happen. So we need to plan for that. So I think going forward, the U.S. will learn to think about the FDA regulations, as well as having some redundancy for developing tests.
Okay. And then our last question related to testing has to do with the sourcing of tests from the WHO. I think there were some tests available. They weren't accepted for some reason. Can you provide any background on that story?
There was a test developed by Germany. In Germany, they had a test that then was adopted by WHO and was being used in other countries. And I think this is one, if there's a lesson here, CDC, quite frankly, usually leads the world in the development of testing. And they've been such a leader, and this is just one that I think took folks by surprise, that the test would be faulty. And so there was a reliance on that we were going to have our own test coming out of the CDC. In retrospect, going ahead and using that test that WHO had approved would have been probably a good idea.
Okay, thank you. All right, let's turn to some questions regarding vaccine and vaccinations and the creation of vaccines. And anyone who has either studied the vaccination approval process or invested in that process knows that it can be very lengthy in time. It can be very expensive. It does seem like at least the news flow is that we're racing to get things done sooner rather than later, but we keep hearing it's still going to be an 18-month process. Could be even longer than 18 months. Can you just talk to the reality of a vaccine in 2020? Is it more likely to be in the next 18 months? How should we think about that?
It's more likely to be later. I mean, that would be very optimistic to think that we'll have a vaccine by this fall, just because of the way vaccines need to be tested. So it will probably be in 2021. But these trials, I think what's so unique and is exciting is that to have 6 vaccines already in human trials is pretty much unheard of in the timeline that we've been in. But again, it's those unknowns. Until you have those human trials and until you can prove that you've got a safe vaccine, because the last thing you want to do is develop a vaccine then that causes more harm than good. And so that's why we have to have the trials. And then to develop a vaccine that is not effective and to take and to begin to try to mass produce and vaccinate folks with a vaccine that isn't effective, that's a huge waste. So we've got to mitigate against those, and that's why it takes time. It really does.
Great. Okay, let's turn to tracing for a moment. So a member of the GIC is commenting that we appear to be 300,000 short of contact tracers. And the question is, what is the CDC doing about this? Is there leadership at the CDC focusing on the tracing activity? And can the CDC be more assertive?
Yeah, no, that's a great question. And so CDC, I'd mentioned before, CDC is putting a lot on their website, and every day there's more and more out there. So you can actually go read about their approach. They just posted, they've got a multi-pronged approach to the contact tracing. So they are, first and foremost, the states are receiving funding, and the states can use the federal funding for contact tracing. And many states are beginning to ramp up. We see in Massachusetts, they've gone with Partners in Health as one of their partners, and they're hiring 1,000+ contact tracers. I can't remember the exact number. New York City is out of the gate looking at that, and other jurisdictions. The CDC also then is sending some of their own staff into the states to help surge the staffing. They've asked the CDC Foundation to hire additional staff. We're also, there's a lot of work right now with the Peace Corps volunteers that have come back. There's a discussion that we've got folks that had been hired to do the census that could be contact tracers. So they also are looking at kind of armies of people that are ready to go that can be trained. The other thing that CDC is doing, they've got training that they have put together for contact tracing, because obviously this is all new for anybody coming into this. And they're partnering with the Association of State and Territorial Health Officials, just launched a training as well for the states, and they're in partnership. And then, of course, Johns Hopkins University is another partner, and they've been involved with the training that I think will launch next week for the contact tracing. So there's multiple things happening. But at the end of the day, the states will be the ones that will ultimately decide how they're going to hire the thousands. And they'll do that in varying ways.
Okay, thank you. There's a question here. Can you talk about the people being reinfected? We're starting to hear stories of positive cases, they cure, but then the reinfection seems to be coming back. What's the latest there?
Well, I think this is the part of the being a novel coronavirus, and it's an RNA virus. I mean, that's different than your DNA viruses, a little more challenging actually to develop vaccines. That's the other, just to go back to the vaccines a minute, that makes it a little bit harder, or maybe a lot harder sometimes. The reinfection is something, this gets back to the serology, right? If you have antibodies, do those antibodies actually protect you from reinfection? We just don't know. We don't know. So as we begin to see people being what looks like reinfection or proven to be reinfection, that's where the studies need to be done. I'm not up on the actual numbers of reinfection. I don't know that I've seen that number, but I'm not necessarily surprised that we might see people be reinfected.
Okay. So I'm going to turn to, there's a host of questions about, I'm going to call it governance. One question here is, what's the operational relationship between the CDC and the administration?
Well, so CDC is, it's one of the operating divisions under Health and Human Services. So you have HHS, and of course the secretary reports to the president, and then the director of CDC reports to the HHS secretary. So that's the structure in terms of reporting.
And then how about with the FDA and the NIH?
Yeah, so they're sister agencies actually. So they have exactly the same, the Health and Human Services, the secretary has under him, NIH would be one of those operating divisions. FDA is an operating division, and there are a number of others operating divisions, like the Indian Health Service reports up through HHS. So it's the same. They all have this. The directors of all those agencies have the same boss, and that's the Secretary of Health and Human Services.
Thank you. Question here, can you comment on what appears to be the increasing political impact? There appears to be political pressure on the CDC. Care to comment?
Well, my own feeling is that we're in a pandemic, and so we need to be driven by science. And I will tell you, CDC is full of really dedicated individuals that are putting out that guidance. I mentioned over 1,000 approved guidance documents that have gone out now. And so they're driving hard to get the science out and working with the state officials, the state health officers. So
Okay,
I try to stay out of the politics.
very smart. What is the impact on the CDC, if any, of the U.S. non-funding of the WHO?
I haven't seen an impact yet. I mean, sometimes CDC, there is obviously the U.S. does fund the WHO. I mean, for years they've been a funder. Some of that funding comes through CDC to WHO. So I would imagine that CDC is looking at other avenues to get the funding to the international partners, to the different countries, and rather than through WHO. But I don't know. I'm not sure.
Okay. There's a question here. We're going to change tack just a little bit away from governance. Given the precedent globally of other epidemics and pandemics, why were so many countries so ill prepared?
This goes back to the global health security agenda. First of all, I mean, clearly there's a lot of competition for funding. I mean, there are a lot of things that we need to think about in all societies and all countries. But the problem with public health is that it tends to get attention, intense attention, when there's a major epidemic or a pandemic of this nature. And then once it gets solved and we move on, it tends to be forgotten. And then we go right back to the chronic underfunding. And so the simple answer is there's not been enough funding over the years to assure that all the countries have the expertise, the training, and the not just the knowledge, but having the laboratory capacity and so forth to be ready for something of this nature.
So sort of related to that question, if you had to categorize the 3 lessons learned, the major lessons drawn from the pandemic to better prepare either for a second wave or future pandemics, what are those 3 lessons?
Yeah, well, first and foremost is building that public health infrastructure. I mean, that's lesson number 1. We need to build it and we need to maintain it. We can't let that slip. That's a big one. I think I mentioned before supply chains, because it impacts the laboratory, it impacts our personal protective equipment. I think we do need, and I think countries will be looking at supply chain issues differently. And so there was too much reliance in my mind in this one, in one part of the world, and that came back around. But it's also maybe the third lesson in this is that when we do deliberate planning, like the pandemic influenza planning that I mentioned before that took place, those plans are, if they've been done by thoughtful citizens, scientists, a lot of input, we need to take those seriously. We need to take our after action reviews that we do after every event, and those need to be turned into real solutions that we actually apply the next time around. I've been in public health since 2005. Prior to that, practicing medicine, and if there's one big lesson I've seen is that too many times we end up repeating the lessons. My husband used to tell our kids that lessons will be repeated until they're learned. Well, how many times do we have to continue to learn the same lessons? So I think as a society at large, we just have to take public health more seriously because it's a whole lot cheaper to prevent than it is to have a pandemic, as I think we're all seeing.
So there's a question, how helpful has China been to the CDC in understanding the details behind the novel coronavirus?
I'm not with CDC now. I'm being over at the foundation, but CDC has had they've had a country office in China for a number of years, and there's been I think, you know, a lot of exchange between the scientists, but I can't speak directly to what's happened specifically since I'm not there, but I know there's been a long relationship.
Okay. And this will be our last question. It's kind of going back to something you said with regard to tracing and that being left up to each of the states. Is there anything the CDC can do to push the states? And associated with that, are there any federal budgets being set aside for contact tracing?
Yeah, I mean, so funding is going to the states, and I think maybe this next stimulus package may be even more specific for the contact tracing. But funding is flowing, and CDC receives funding from Congress, and then they put the funding out to the states. I believe every state has to have a plan for how they're going to do their contact tracing. So that's typically the way that would work. And then CDC also puts out guidance. They're putting out very, very detailed guidance for each of the states for how to do this. And then they have public health advisors that are advising each state. So every state health officer has access to advisors coming from CDC that are all working to try to learn the best practices. I mean, you know, what are we going to learn from Massachusetts? What are we going to learn from New York? Some of the ones that are out of the gate, the earliest, those are the ones we need to learn rapidly from and assure that other states are applying the best lessons.
Okay, great. Well, Dr. Judy Monroe, we really appreciate your insights. You're spending time with the GIC to share with us what's happening at the CDC Foundation. If members want to learn more about the CDC Foundation, what's the best way to reach out? Is it through the website?
Yes, I think so. The CDC Foundation.org, it's probably www.cdcfoundation.org. But yeah, you can Google us, you can find us pretty easy.
Okay, fantastic. Well, we appreciate your joining us today. Want to thank all of you for joining us as well. Thank you for participating in our audience survey. Just as a reminder that we're going to be continuing these through the summer. So our next 2 or 3 programs coming up. Next week, we're going to have a view on the European economy. The week after that, we will have some commentary with regard to the economic impact to small businesses in the United States. And then we'll wrap up in the month of May with some monetary policy expertise from the Atlanta Fed. So we're looking forward to that coming up. But as a reminder, the GIC is bringing this to you as a public service. We are a non-for-profit 501c3 organization. If you are interested in making a donation, more importantly, if you'd like to become a member of the GIC, you can do so by going to the website. That's www.interdependence.org. And today's presentation will be made available as a replay. The slides will be available there as well on the GIC website. So thank you all for participating, and good afternoon.